just before the termination in the lateral sac, there is an area called common canaliculus. There is an area called common canaliculus. Then it goes into the lateral sac. It goes into lateral sac. From the lateral sac, it has three parts. One is the fundus, which is above the medial canthus. That's called fundus. Then the body of the sac. Then the nasolacrimal duct. Sorry, then the tail of the lacrimal sac. Then the nasolacrimal duct. So nasolacrimal duct is around 12 mm. How much? 12 mm. And it has two parts. One is called bony part and other is called membranous part. Other is called membranous part. You can just see here. You can see here there is lateral sac, there is nasolacrimal duct, which is the bony part and the membranous part, and that opens into the inferior meatus of the lobes. Inferior meatus of the lobes. That's how the tears are drained into the lobes. Here, I will emphasize two things more. One is called that which has a clinical relevance. One is the lacrimal pump system. What is the lacrimal pump system? What is lacrimal pump system? The lacrimal pump system is that once we close the eye or we blink, there is a negative pressure created by the orbicularis. A negative pressure is created in the sac, which sucks the tears into the sac. Okay? Then they are drained into the inferior meatus. Once they reach the sac, then they will be drained. So if there is no lacrimal pump system, it's not effective. Everything is normal. There is no block anywhere. But lacrimal pump system is not effective. Orbicularis is not constructed normally with the blink of the eye. And there is not the negative pressure is not generated in the sac. This is called a functional block. This is called a functional block. This is called functional block. Then one more thing is the direction of penalty. One more thing is the direction of remembrance. That is lacrimal pump healing and number second is what is the direction of penalty. What is the direction of penalty? Anybody can tell me? Direction. Nasolacrimal duct. This is a very important question in all MCQs, and it's a very important question from clinical point of view also. You understand? So, suppose just imagine that there is a block in the nasolacrimal duct here. There is a block here or here. So we have to pass. We should know the direction. Once we are passing a probe, we should know the direction in which we are going. We cannot create a false passage. So we should know that. You don't know, nobody knows? No. It is posteriorly, downwards, posterior and lateral. Okay? Posteriorly, downwards and lateral. Okay? So suppose I go with the probe. So I have to first go to the canaliculus. I have to dilate the punctus. I have to go to the sac. Then I will shift it 90 degrees like this. Suppose I am going like this. Okay? Then I will shift the probe 90 degrees. Then I will go slightly laterally like this. Then I will go slightly posteriorly and laterally. So I will go in this direction, like the lateral wall of the nose, in a posterior direction, in a downward direction. So downwards, posterior, laterally. Remember these things. Downwards, posterior, and laterally. What? Downwards, posterior, and laterally. So that is how because once, suppose this is, I will explain this again. Suppose this is a counter. We go here. Okay? Once I reach this, I will shift my hands here, this point, just supraorbital, like this. Okay. Now I will go posteriorly, laterally, and downwards. Okay. Now I will go into that. So if you go suppose like this, you will create a false vestige. If you go more anteriorly, you will create a false vestige. So if you go superiorly, you will create a false vestige. Or you go anteriorly, you will create a false vestige. So the direction has to be downwards, posteriorly, and laterally. I think I made my point. Because this is very important in children. When there is a block at the valve acid, that is where it opens here in the inferior areas. Suppose there is a block here. There is a block here. There is a membrane here. So we want to break this membrane. We want to break this membrane. So we have to do a syringing and probing. So we have to follow this direction. So that we break that membrane here and the nasal lacrimal duct becomes patent. So I have highlighted these important things. Then we can have some idea about the tear film. Tear film has three parts. It has three parts. It has the superficial is oily layer, middle is the aqueous, and the adherent to the epithelium of the conjunctiva and cornea is the mucin layer. So it has three layers. How many?
Three layers.
Mucin, aqueous, and the
Mucinous.
mucin is the innermost, aqueous is the middle, and the oily layer is the superficial. Why oily is superficial?
Lighter than water.
Yes, it is lighter than the water, so it will not allow the things to evaporate. Like in a sea, will throw oil, so water will not evaporate. So nature has created such a thing that it doesn't evaporate that easily, and I used to mean that all the time. because the corneal transparency, one of the factors is the tear film. Is the tear film integrity, tear film smoothness, epithelial smoothness, which is created by the mucin aqueous layer. Then the other thing is the constituents of the tear film. Mucin is secreted by what? Mucin is secreted by the goblet cells. Mucin is secreted by the goblet cells and the conjunctiva. Then the aqueous is secreted by the lacrimal gland. And the oily layer, that is superficial layer, that is secreted by what? That is secreted by mebium glands. Yes, mebium glands are present where? They are present in tarsal plates. They are present in tarsal plates. So these are the three layers. Then what is this tear form? It's mostly water. It's mostly water. Slide shift.
चलो आप ही के पास हाथ में कर
These things I already talked about. So tears has these 98% water, then it has protein, albumin, globulin, then it has lysozyme, and urea, then potassium, sodium, or chloride, or higher than the plasma. Then pH is 7.3. And osmotic pressure is 1.4% of saline. So this is the tears. Okay, this is the direction of tears. what are the symptoms? First symptom is this watering, or what's called epiphora. That's called watering or epiphora. Then there is swelling. There can be swelling in the lacrimal sac area or around it, which can be painful or painless. Or there can be some deficiency of the tears, which can lead to dry eyes, and that's called keratitis secca. And once the cornea gets dry, you lose the vision, because cornea should be always red. Now let's go directly on the top. Before we move ahead, so what is the dacrocysyitis? It is the inflammation of the lacrimal sac. It is the inflammation of the lacrimal sac. And it can be inflammation of the nasolacrimal tract. Okay? It can draw us to that. So what are the causes of inflammation of the lacrimal sac? Or what are the causes of the dacrocysyitis? So first classification is it can be congenital. It can be congenital, and other is acquired. Other is acquired. Congenital means it's present at birth. It's present at birth. Acquired means it is acquired later in life. So when it's present at birth, what is the problem? There is a, what I told you, there is a block in the nasolacrimal duct near its inferior max at the valve of Hasselhoff. So there is a membrane there, and that obstructs the energy. This is in the congenital. But watering does not appear at birth, because tears are formed in the eyes at 3 months. They are formed in the eyes at 3 months. So child starts watering from 3 months onwards. And with watering, there appears infection of the conjunctiva, and there is conjunctivitis also, which is recurrent. Then in the adults, we have two types of this. One is primary, other is secondary. One is the primary, other is the secondary. What's primary? Primary, there is inflammation in the nasolacrimal duct. There is the cause is not known. There is a paraductal inflammation. And what is paraductal inflammation of the nasolacrimal duct? That leads to inflammation, that leads to epithelial abnormality, and that leads to fibrosis, and fibrosis close the nasolacrimal duct. So once there is obliteration of the nasolacrimal duct, it's called primary nasolacrimal duct obstruction. What's called?
Primary nasolacrimal duct
obstruction. What's called, some people call PANDO. PANDO. Primary acquired nasolacrimal duct obstruction. Then there can be secondary. Nasolacrimal duct obstruction. There can be secondary nasolacrimal duct obstruction. What can be the cause of secondary? Secondary means secondary to some. Secondary to some disease. What are secondary diseases which can cause?
eye infections. Eye infections.
Yes, sometimes, but they are not called. If there is a granulomatosis, there is a granulomatosis or polyangiitis or sarcoidosis, suppose nose granulomatosis, or there is a, which can obstruct the duct. Okay, then polyangiitis, then sarcoidosis. So these can be secondary causes. Even some, suppose malignancy in the nose, which can obstruct the what? They can obstruct the nasolacrimal duct. Even sinus tumors, maxillary sinus tumors, they will obstruct the nasolacrimal duct. Then more aside from these causes, there can be sometimes drugs. Some drugs cause obliteration of punctal stenosis, or they cause nasolateral type block. What are the drugs which cause? Beta blockers, timolol. Which beta blockers? Pilocarpine, that can cause. Then some antiviral drugs. Some antiviral drugs like hydroxyuridine, which is not used in India, that's used in USA or in America for herpetic arthritis. That's hydroxyuridine. Okay, so they will cause nasolateral duct blockage. These were some of the drugs. Then what other thing causes infection? Okay, like streptococcal infection, staphylococcal infection, pneumococcal infection, hemophilus infection, or pseudomonas infections. They can cause nasolateral duct obstruction. Then, aside from these, one of the most important causes of allergy is the trauma. If somebody has fixed blood trauma, apparently there will be abrasion in the lip. And then, secondly, after some time, she develops or he develops epiphora. So there was energy damage at the time of trauma, even with the blood trauma. Then, if there is a more severe trauma, like which can cause a fracture in the nose, or which can cause this fracture in the upper part of the face, then damage the nasolateral duct. Okay. Then even some surgeons do what's called iatrogenic trauma, by surgical trauma. What iatrogenic trauma can cause allergy block? Like somebody is doing endoscopic nasal surgery, sinus surgery, he can damage the allergies, and it can be an iatrogenic trauma to the allergy. Then even some maxillofacial surgeons who are operating in this area, they can damage the nasolateral duct. Then other causes of obstruction are the tumors. There are the tumors like squamous cell carcinoma or adenocarcinoma. Even suppose there is basal cell carcinoma in this area, which can go and cause the infiltration of the invasion of the nasolateral duct. That can cause nasolateral duct obstruction. Then one more important is that somebody has been given radiotherapy in this area. So radiotherapy causes allergy damage, and that can cause allergy obstruction. That can cause secondary dacrocysyitis. This is called SARDO. And this is called ANDO, and this is called SARDO. SARDO means secondary acute lateral duct obstruction. So these are some of the causes which I have tried to explain to you. Then once we go directly down the clinical profile, we go to the clinical profile. Which of the patients it affects? It affects generally females. It affects females. So once it affects female, then there is in which age group it affects? In which age group it affects? In which age group it affects? It affects in the age of 6th or 6th. That is after 40. After 40. So it will affect, it is affecting females in the age of 40 or 50s. Okay? Then once it affects in this age, why females are more prone? There are some factors why females are more prone to nasolateral obstruction. One of the things is the canal is long and is small. Canal is long and is smaller than males. Then other things in them is there are some hormonal Hormonal disease. Suppose in a post-menopausal woman, the prolactin receptors become less. They become less, and that predisposes to the nasolacrimal duct obstruction. Then one more cause is there are some vascular causes. There will be some vascular causes, varicosities, which are present in the lacrimal sac and energy. They have autonomic regulation. They have autonomic regulation. Sometimes severe dysregulation causes a nasolacrimal duct block. This is one more what is called there is normal commensals in any part of the body. In the eye also there are normal bacteria and viruses. So if there is some disproportionate increase in one or the other, that leads to inflammation. That leads to inflammation, and that can cause an allergy problem. That's called lacrioma. That's called lacrioma. So there is a sort of an inflammation by invasion by different class of bacteria or viruses. So these are some of the factors which are elucidated that why there is inflammation in the nasolacrimal duct and why the females are more prone to allergy obstruction. So what happens in the nasolacrimal duct, the pathology, there is occurs a paraductal inflammation. It's called inflammatory phase. It's called inflammatory phase. Then there occurs a spotty involvement of the epithelium. This is called intermediate phase. It's called intermediate phase. Third is, once there is inflammation reaching to the epithelium also, there is fibrosis. This is called fibrotic phase. It's called fibrotic phase. Once it is the fibrotic phase leads to the allergy obstruction and closure. And that leads to dacrocysyitis. Now, coming to the clinical spectrum, suppose now we have two types, acute, chronic. We have two types, acute and chronic. Acute, acute you understand. Acute means acute. Chronic means chronic. Okay? What can be features of acute? Suppose patient, middle-aged female, she enters into a OP and there is a swelling here, which is very bad. She has a pain. Once we touch the swelling, there is tenderness, then there is some pain around a preceptor cell lines. Okay? And there can be some pus formation also here. Okay. So this becomes the diagnosis of acute dacrocysyitis. Okay. If somebody asks you what are the features of acute dacrocysyitis, you can tell a patient complaining of pain in the lacrimal sac area, then on palpation is tender, on palpation is tender, and then patient can have a malaise, she can have a fever, then it can lead to surrounding edema. Once the preceptor cell lines, we label it as acute dacrocysyitis. And in the acute dacrocysyitis, this inflammation can lead to abscess formation, which can drain off spontaneously, or there can be pus point. You can put a blade here, you can drain it off. So it becomes a treatment also, just giving an incision in the abscess area. So it can lead us. What is contraindicated in acute dacrocysyitis? You should never do syringe. You should never do syringe because inflammation will spread. The infection will spread. So we never do a syringe in acute dacrocysyitis. This is the golden rule. It's a golden rule. Number one. Number two. Suppose now there is acute dacrocysyitis and how you are treating it? You can give a culture sensitivity, you can then change it also. Because there is now growing resistance to the amoxicillin. The idea would be to start with amoxicillin and then take the culture and go by the culture reports. Give the antibiotics as per the culture reports. Then you can give anti-inflammatory also. Then you can give anti-inflammatory like a brufen, diclofenac, like that. Then you can give topical antibiotics also, or topical antibiotic ointment also, because you don't want this acute dacrocysyitis should cause conjunctivitis or should cause eye infection. So you want to protect the eye. So this was the management of acute dacrocysyitis. Then we go to the chronic dacrocysyitis. Here I want to illustrate one important point, that the lacrimal swellings. Suppose these are some of the pictures of acute dacrocysyitis. So this is swelling in this area. This is the lacrimal sac. This is the lacrimal, and this is swelling around it. This is sunlight. Then this becomes an abscess. So if it drains somewhere, it can lead to a fistula, which will have a leakage. This can be a deep fistula type. So acute dacrocysyitis can have some complications. Then we go to the chronic dacrocysyitis. Before we go to the chronic dacrocysyitis, let me make it clear how we can differentiate lacrimal sac swelling from other swelling. So there can be thyroid, there can be something else. How we can differentiate? Where is the lacrimal sac situated? It is below the anterior lacrimal crust. Okay, this is the lacrimal crust. Behind it, there is one anterior lacrimal crust, there is posterior lacrimal crust. There are two crusts, anterior and posterior. Between two is the lacrimal sac. So any swelling below the medial canthus, is lacrimal sac. Any swelling below the medial canthus. If there is swelling above the medial canthus, what you can do? Sometimes it can be ethmoiditis in children. Ethmoiditis. Okay. So never make a diagnosis of dacrocysyitis if it is above the medial canthus. Suppose there is swelling above the medial canthus in this area, never make a diagnosis of dacrocysyitis. You should ensure it is below the medial canthus. So chronic dacrocysyitis, now it leads to inflammation subsides and this and that. They become the first permanent enlargement of the lacrimal sac. There is a swelling here. Patient comes and the OP, she is telling that I have watering. Once you examine, there is swelling in the lacrimal sac. Once there is swelling, once we touch it, it's non-tender. It's not tender on palpation. Once we just press it, the pus comes from the, or the fluid comes from the lower punctum. This is called Rocklaw's positive. This is called Rocklaw's positive. Regurgitation of pressure of the swelling. Once we press the swelling, the pus comes from the lower punctum, or the mucus comes from the lower punctum. So the swelling in the sac area here, it can have mucus in it, which is secreted by the epithelium of the lacrimal sac, or it can get infected. It can have pus in the lacrimal sac, and both of these things can lead to regurgitation of mucus or regurgitation of pus from the lower punctum or pressure of the swelling or pressure of the sac. So this is called Rocklaw's. If there is mucus in the sac, it is called mucosine. If it is pus in the sac, it is called pyosine. It is called pyosine. Once we do syringing in them, classically, once we pass this cannula and we do syringing in them, there is regurgitation from the upper punctum. Fluid is not going to the throat. It's not going to the nose. there is regurgitation from the upper abdomen with pus. With pus. So that's classical of chronic dacrocysyitis. That's classical of chronic. So before I proceed to other investigations, just I want to highlight two things. So once we see a patient of epicora, she is entering in our OPD, what things we should look at? First of all, we should look at the lids. We should look at the lids. We should look at the lids. Whether the lids are at its full place. Because suppose there is ectropion, lid is out, it can lead epicora. Suppose there is even facial paralysis, leg of temple. Okay? Because orbital mass is paralysis. What I told you, lateral function in facial paralysis. That can be good. There is if you see quantum, there is a stenosis of the quantum. It is smaller or it has obstructed. That can lead to. If there is canaliculus obstruction, suppose what happens? These chronic dacrocysyitis patients, they come to the hospital and every time they can have these doing syringing. So somebody makes a false passage somewhere and it can lead to canalicular obstruction. It can lead to canalicular obstruction. Okay? So then we have to see whether the canaliculus are patent. Then we have to see whether the sac is, whether there is obstruction in the common canaliculus. There can be obstruction in the common canaliculus. Then there can be obstruction in the nasal abdominal duct. Then we have to differentiate all these. First, we have to see that maximum lacrimal secretion is passed through what? From the lower bone. From the not from the upper bone. From how much is from the lower bone? 90%. How much? 90%. Only 10% is drained from the upper bone. 90% is drained to the lower bone, and only 10% is drained from the upper bone. So while doing this syringing, we should understand some things. Suppose we do a syringing and fluid does not go down into the throat or into the nose. That means nasal lacrimal duct is obstructed. There can be some other you can have a common canaliculus obstruction. It is passed through. Common canaliculus comes to pass, but it does not go into the sac. It stops at common canaliculus. Once we do a syringing in them, it will come immediately from upper bone. It will come immediately from upper bone with a clear fluid. With a clear fluid. This is called a soft stop. This is called a soft stop. Suppose there is an energy block, there will be a hard stop. Because once you pass the canal, it will reach to the lateral side. It will reach to the bone. Okay? So once it will reach the bone, it's called hard stop. Once we energy block, once we do the syringing, it will be passed from the upper bone. In common canaliculus, it will be with water. It will be fluid. It will not be with pus. And first soft stop in common canaliculus, hard stop in energy. Okay, this is the difference. Then number second, clear fluid in common canaliculus and pus in nasal lacrimal duct. Third, while we do syringing, there will be immediate fluid because common canaliculus does not have to go into the sac. So there will be immediate regurgitation from the upper bone. While in case of energy block, it will go to the left. It will take some time to come from the upper bone. So there will be some delay of seconds, not minutes. There will be delay of seconds once you intake. These are the three differences between a common canalicular block and an energy block. Again, I will repeat. In common canaliculus, there will be a soft stop. In energy, there will be a hard stop on syringing. In common canaliculus, it will come immediately. A clear fluid from the upper content. In energy block, it will come after a gap of 30 or 45 seconds. Third, in common canaliculus, there will be clear fluid jutting from the upper content. And while in case of nasal lacrimal duct obstruction, it will be pus, fluid mixed with pus from the upper abdomen. I think I made it clear how we can differentiate these. there can be other investigation. There can be other investigation, like a fluorescein. Fluorescein, we put fluorescein in the eye, we see its pass. We see it is pass. We see it is pass. Then there can be X-ray. There can be X-ray like dacrocysyitis. We put some dye in the canonical system. Then we take repeated X-rays. We should see the pass of the dye. We see the pass of the dye. That's called dacrocysyitis. That's called dacrocysyitis. This is like that. We can see later on that, we can see energy like that. I will go back to the fluorescein, this, because that's very important to know. So the patient is at 4. Patient is at 4. We put fluorescein in the eye. We put fluorescein in the eye. Then we put a cotton tip applicator in the nose, near the inferior ears. Okay, we put some dye and we put it there. That's put after 5 minutes. That's put after 5 minutes. If that's stained, that means what? Energy is fading. Okay, if that's stained with green dye, that means nasal lacrimal duct is faded. This is called Jones 1 test. This is called Jones test. Suppose it is faded and there is still absorbed. What can it do?
Functional.
Hypersecretion. Hypersecretion of the tears. Now we have, suppose it is not coming. This is called positive Jones. This is called positive. Now it is not coming. This is negative Jones one. This negative, what can be the cause? Huh? Okay, there can be obstruction of the nasal lacrimal duct. Anything else? Huh? No. Canonical obstruction, yes, then you will not able, the fluorescein will not go into the canonical system, into the lacrimal sac. That's very easy, because on syringe you can come to know the canonical system. But more important than this is nasal lacrimal duct obstruction and some pump failure, what I understand functional sac, functional. Okay, how you will differentiate between those two? What do you do? Once it has not come, it has not come. So Jones 1 is negative. Okay, you have put fluorescein, it has not come in the nose after 5 minutes. So Jones 1 is negative. Now you wash the dye from the container. You wash the dye from the container. Now you do a syringe. You do a syringe. Now, if it goes down and it becomes positive, the swab becomes stained, it is probably energy obstruction. It is energy obstruction, not complete partial energy obstruction. In complete, it never nothing will go down. So it's a partial energy obstruction. If no dye still comes, no dye still comes, then it's a functional. That is a functional pump. It's a functional pump. Can it be explained? Why in functional this there will be no dye? Because I told you, put the dye in the eye. Once this pump fails, the sac will not suck this
Negative.
fluids in the sac. It will not reach the sac. Okay. It will not reach the sac. Once it does not reach the sac, even the syringe it will not come. You understand? So, in the functional failure or the pump failure, the dye will not reach the vein. Go after syringe. Okay. While in case of energy obstruction, on syringe, it will reach the inferior vena. It will reach the inferior vena. We do a DCR procedure, it's called dacrocysyitis. That's called dacrocysyitis. We instrument the sac. We instrument the sac with the nasal glucose. With the nasal mucosa. What we do, we give an incision. We give an incision in this area. In this area, we give an incision like this. First, we do a drop here and here in the nasociliary nerve area. Which nerve? Nasociliary, which is the division of trigeminal or thyroid division. So, once we give the drop, then we give a descending incision. We just separate the organ glands. We reach the anterior lacrimal crust. Then we separate the sac. We separate the sac. Then we nibble the bone. We break the bone. We make a big window. And then once we have made a big window, then we cut the sac vertically like this. We make two flaps, anterior and posterior. With sac also we make, nasal mucosa also we make anterior and posterior flaps. Then anterior we can anastomose, posterior we can anastomose. Nowadays posterior is not anastomose, that's cut. Just anterior is end. So it makes an anastomosis. It makes an alternating drainage system. This is called dacrocysyitis. Then once we make dacrocysyitis, we can put a silicone tube from the upper punctum and lower punctum. Okay, that will make a passage. But previously it was said that silicone tube should be put for a long time, like 6 months, 3 months. But nowadays the recommendation is only 1 month, because there is inflammation around this tube, which can lead to this fibrosis. Then what can be the complication of the surgery? Suppose you have made incision 3 mm from the medial cancer or 8 mm, because there is angular vein here, either 3 mm or 9 mm. Because in between there is angular vein which can bleed, it can lead to bleeding. Then there can be other complications, like suppose what can be the cause of the failure? What can be the cause? Suppose somebody has not opened sac during surgery, it can be failure. Suppose there is a small bone window which has been cut, that can lead to fibrosis. Suppose there is you have made superior window, inferior there is still a gap, that's called sum syndrome. You have made a window in the bone, but that's superior. Inferior there is again a collection. Okay, that's called sum syndrome. That leads to regurgitation. Or there is atrophic nasal mucosa, because we do an ENT consultation before doing a DCR. Suppose there is atrophic nasal mucosa, which can lead to fibrosis, which can cause the failure of the DCR. So these are some of the complications of DCR. The other procedure is dacrocystectomy. We remove the sac, that's it. We cut the sac and do. Incision is used superiorly, because we want to go to fundus. We want to remove the whole part of the sac. We don't want to make flaps. That's called dacrocystectomy. If we do in those patients, if it is mature cataract in both eyes, we are in a hurry to do the cataract, so we want to just remove the infection from the sac. That's called dacrocystectomy. Or other indication is if there is a tumor in the sac. If there is adenocarcinoma of the sac, we can do a dacrocystectomy. Then there is one more procedure that's called laser DCR. That's called laser DCR. The laser probe is put through this lacrimal punctum. It goes to the sac, into the sac. It breaks the bone, but it makes a very small window. Generally, we have seen people who have done here or outside this, they get again also. Because the small window closes and it leads again. One more procedure is the endoscopic DCR. That's the ENT surgeon are doing. They go through the nose, make a window in the middle terminate area, connect it with the sac, and that is a bypass the endoscopy. That's called endoscopic DCR. But the problem with that is, again, you may have to do repeated surgeries sometimes in that one. Because there is a canonical problem. They cannot address it. There is a common canonical problem. Then we have to extend the lacrimal system by the silicone tube. So the external DCR, what we are doing outside in the ophthalmology department, that is the highest success rate. Endoscopic, laser DCR, they have lesser success rate. Okay, all the best.